Hello, everyone, and thank you for joining us today. We're just about ready to get started for our presentation on the CAUTI Compendium updates. Just going to give it a moment so everybody can get joined and connected, and we will begin our presentation. All right. So today's presentation is coming to you guys from the South Dakota Department of Health through a contract with the CDC's HAI Antibiotic Resistance Program. Rebecca, if you would go to the next slide, please. So the HAI AR program is supported through funds provided by the Centers of Disease Control and Prevention in the South Dakota Department of Health. Public health is the science of protecting and improving the health of communities through efforts such as promoting healthy lifestyles, preventing disease and injury, controlling infectious diseases. It plays a vital role in our society by preventing epidemics, protecting against environmental hazards, reducing injuries, encouraging healthy behaviors, ensuring access to quality healthcare services, and responding to disasters to support community recovery. Public health is not just one organization. It's a system of partners working together, including state and local health departments, tribal health organizations, healthcare providers, emergency responders, schools, community coalitions, and even elected officials. Together, these entities strive toward the vision of every South Dakotan healthy and strong by collectively promoting, protecting, and improving health across the state. I want to thank you again for joining us. We are going to go ahead and go to the next slide and turn it over to our presenter and let her do her introduction.
Well, thank you so much, and thank you everyone for inviting me and allowing me to talk a little bit about the compendium. I'll talk generally about the compendium of strategies to prevent HAI, but really with a focus on catheter-associated urinary tract infections. So I hope that this is informational for you, and then that I'm happy to take questions at the end. Next slide. So I have no conflicts of interest to disclose. My primary appointment is at the Veterans Affairs Hospital in Ann Arbor, Michigan. So the opinions that I express today are not those of the VA or of the United States generally, but I am primarily an infectious disease physician. I do some internal medicine rounding at the VA as well. And so CAUTI is near and dear to my heart, as you might imagine. These slides are courtesy of my colleague, Dr. Payal Patel, who was the primary author on the CAUTI Compendium. And so I'm grateful to her for the slides she shared and with some additions of my own. Next slide. So my objectives here, and you can kind of scroll through these. My objectives for today, if you don't mind going ahead, thank you. So I'm really just going to talk about some of the changes and some of the new additions to the CAUTI compendium. If you've looked at the compendium, it is a lengthy document. So I'm really going to try and highlight some of the changes that were made with this new iteration, which summarizes ways to prevent CAUTI. We're really going to look a little bit at diagnostic stewardship and antimicrobial stewardship, which is, I would say, one real highlight of the updates to the CAUTI compendium for prevention, and really brings in that infection prevention piece, which is so important. And then we'll spend a little time talking about infectious versus non-infectious harms associated with CAUTI, which was another real emphasis of the updates made with the new compendium. Next slide. This is just a list of acronyms for your reference. We're not going to be talking about all of these things today. The focus is going to be on CAUTI, and I will talk a little bit about C. difficile, but all of these are related to healthcare-associated infections and the series of compendiums that are put together. Next slide. So before, kind of diving into the CAUTI piece of things, I just wanted to take a moment to kind of talk a little bit about how guidelines can be helpful when we think about empiric decision making and where they can be helpful in those clinical moments. Next slide. So I find this image really helpful. As you all know, oftentimes when patients present to the hospital or in those moments where we aren't certain what is going on, new symptoms emerge, there's a really low level of diagnostic certainty. The risk is higher, particularly we think about this with patients who are septic or presenting with septic shock. And so these are areas where guidelines can be really helpful. Risks are high. We want some guidance to kind of get us to the appropriate diagnosis, but we also want to protect the patient as we're trying to figure out what's going on. Next slide. And then, as time goes on, as we gather more information about the patient, we get more laboratory information. Perhaps the patient is responding to some empiric treatments. We start to understand what is happening, and that diagnostic certainty goes up, and the risk goes down. And guidelines are not as helpful in that scenario. So I think it's kind of important to sort of get a bird's eye view of like where it's helpful to use guidelines. And certainly with respect to CAUTI, and CAUTI can sometimes present as a fever. It can sometimes present in those kind of uncertain ways. And so understanding how the guideline can be useful in those situations is good. Next slide. So when I say compendium, what do I mean? What is the compendium? So this is a series of strategies to prevent healthcare associated infections in acute care hospitals. This is a collaboration between a number of different societies, including the Society for Healthcare Epidemiology of America and the Infectious Disease Society of America, amongst others. It's really meant to be geared towards acute care hospitals, although certainly can be extrapolated to other settings such as long-term care. And while these compendiums are utilized internationally, the focus is really in the United States. These updates are relating to 7 guidance documents for preventing hospital-acquired infections. And so these are listed here: CAUTI, which we are going to talk about, but also central line-associated bloodstream infections, C. diff, hand hygiene, MRSA infections, surgical site infections, and ventilator-associated pneumonia. Next slide. And one of the real benefits of the compendium is that it is open access. So if you are interested in engaging in work related to healthcare associated infections, if you want some of these tools to put into practice in your own hospital, these are all available for free. They're easy to Google. I've put the link here. And this is really the kind of overall definition, which is that this compendium is meant to provide an up-to-date, concise, and practical recommendations for essential infection prevention practices and guidance on how to build them into the delivery of care. So these are not guidelines per se, but they are kind of a list of recommendations and strategies that can be utilized in your hospital depending on what focus you want. Next slide. So I mentioned that this is a collaborative effort. So these are just some of the organizations that are involved in putting these compendiums together. As you can see, it is a big group. And one of the things that is important to note about the creation of the compendium is that you essentially have both this intense internal review amongst the authors who write and review for the compendium. And then it also goes out to external review. So it has high levels of kind of that intense review process to ensure that the recommendations that come through with the updated strategies are really the most comprehensive that they can be for those healthcare associated infections that I listed. So really kind of a team effort, but you can imagine that it takes quite a bit of time and coordination for these compendiums to come to fruition, so to speak. Next slide. So this is what the CAUTI Compendium looks like. And again, a list of authors from around the country who participated in this study and who are members of these different associations. Dr. Patel is my colleague and was the lead author on this. She and I later went on to work on a review article of the compendium, which gives some additional practical tips. It is not open access, and I am more than happy to share. So if after the talk, if anyone's interested in looking at that review article, I will share my email address. I'm happy to share copies of that with individuals. Next slide. And so that timeline, talking about how long it takes for this to come to fruition. So just to give you a glimpse for this compendium, which just was published in 2022, 2023. So authors were initially chosen in 2019 to primarily write the compendium. They began a literature search later in that year, looking at CAUTI prevention. And by the following year, they were assigned writing sections and began that writing process. But as all of you know, 2020, 2021 was a tumultuous year, so probably also kind of extended out that process to the point where by 2022, a draft was in place and circulating out for internal and external peer review. So really took then a year of review from all of those agencies, including external review for the compendium to be published. Next slide. Great. So this is just coming back to the compendium and really wanting to spend the rest of our time just talking about some of the key takeaways for the CAUTI compendium and updates that was published in this iteration. Next slide. So the document itself is large and it not necessarily easy to read in one setting. But if there is one kind of takeaway that I'd like to say just from a practical standpoint is that all of the main recommendations, the meat of this compendium can be found in these table summaries. So if you don't have time to just sit down and slog through the entire document, I would really encourage you to take a moment and look at the tables and figures that are provided in this document because they really kind of encompass some of the key recommendations and strategies, and it's a little bit more digestible and easier to use. So with that in mind, what I'd like to do is just highlight a couple of them. You can see from this table that this is broken down into essential practices, and then below that you see that it lists infrastructure and resources. Each table lists a different type of essential practice or additional approaches based on the type of recommendation. So we'll just start by looking at just a few of the recommendations for infrastructure and resources with respect to CAUTI prevention. Next slide. So these are some selected recommendations for CAUTI prevention. If you could advance, please. So the first is really to think about performing a CAUTI risk assessment and implementing an organization-wide program that can help identify and remove catheters that are no longer necessary. And so what does that mean practically speaking? Well, we know that there is a lot of literature showing that and studies that have been performed showing that sometimes in the setting of an indwelling catheter, members of the medical team may not even know that catheter is in place. So studies that have asked different levels of healthcare providers, from the medical student to the resident to the attending, to other staff. Does your patient have an indwelling catheter? And how many members of the team actually were aware that a catheter was even in place? So thinking about ways that this becomes kind of the forefront in a patient's care, thinking how there can be daily reviews or ways to implement checklists into the EMR that can help you keep track of which patients have indwelling catheters and conducting that kind of necessary review. Next, please. So a second key recommendation is thinking about appropriate infrastructure for CAUTI prevention. And an example of this is really thinking about some of the non-catheter supplies that are also available. And I'll share a figure later in this talk about some of those, but thinking about female catheters, condom catheters, having things as simple as bedpans nearby, thinking about ways to mitigate CAUTI by preventing the initial CAUTI insertion, or rather the indwelling catheter insertion in the first place, is really key. Next, please. And then thinking about evidence-based protocols to address kind of multiple steps of the urinary catheter life cycle. And so we'll look at a figure about this a little bit later, but thinking about not just the prevention of an indwelling catheter, if it's possible to do so at the beginning, but also insertion, maintenance, and removal. How are there ways that we can optimize our workflow, whether that's through EHR-based interventions, to help monitor indwelling catheters and make sure they are in place only for as long as they are necessary. Next, please. And then this has come out of some literature recently and was something that was one of the newer highlights in this CAUTI compendium, which is um, studies to suggest that for infection control and infection prevention, having trained healthcare providers insert urinary catheters that we have competency that's assessed regularly can really help prevent downstream infectious complications. Next slide. So we talked a little bit about infrastructure and resources. So another section of essential practices is education and training. So again, kind of leading off of that competency for healthcare providers. So educating them not only in insertion, but also just catheter care in general. And that includes those alternatives to indwelling catheters that I mentioned, as well as thinking about how best to prevent infection at every step of that urinary catheter cycle. So insertion, maintenance, and removal. Next, please. And then this is where I think diagnostic stewardship has become a real highlight in this new compendium. And what we've seen is that diagnostic stewardship and antimicrobial stewardship, it's an important union or wedding of these infection prevention and stewardship. And it's really an opportunity for some multidisciplinary collaboration to think about how can we be good stewards of our testing and all of the downstream complications that we can prevent when we're teaching our providers about when a urine culture is appropriate and when it can be withheld. And so thinking about proper indications is really important, and education about that as well. Next, please. This has come out of some literature on appropriate collection of urine, and you can advance again. So there has been some studies in speaking with our microbiology colleagues about how best to collect a urine culture, and so that includes transport time from the moment that collection has been obtained to its delivery to the microlab. And so one of these examples is that thinking about kind of the train from the specimen collection, how long does it take to get to the microlab? They should be collected and delivered in under an hour. There are kind of limitations on how long you can refrigerate a sample, and all with a goal to really prevent contamination and therefore prevent some of the downstream consequences of urine culture results. Next, please. Okay. Some additional essential practices. So again, I think thinking so much about the first step, the step zero of urine catheters, which is it necessary? So really trying to limit the amount of indwelling catheters whenever possible, and then really keeping track of which patients have those catheters and removing them as soon as possible once those indications are no longer in place. Next, please. There has been some good evidence to suggest that working in pairs can help with placement, and that includes patient positioning, monitoring for potential contamination during placement. So, having healthcare providers who are trained, whose competency is assessed, to really work together to kind of limit some of the infectious issues with placement. Next, please. And then This is an important piece. Some of this data, and you will see when you look at the compendium, many of these recommendations are moderate to low evidence. And why is that? Well, there's very few RTCs or randomized controlled trials that kind of give us that strong data. However, we do know from smaller studies that some of these practices can really be beneficial, and we also know that just from our work in the hospitals. And one of those is maintaining unobstructed urine flow. This is where you can really bring patients and caregivers into the infection prevention process. So, kind of reminding those caregivers, reminding transport personnel that the urine bag should also always be below the level of the bladder. And if you advance, it's also important to keep that bag off the floor. Um, and so these are things that we can be mindful of as providers taking care of a urine catheter, but also something that we can educate patients and family about when there's an indwelling catheter in place. Next slide. And finally, you'll see that there is a table that's devoted to additional approaches. And these additional approaches, typically, they require more time, they may be more costly to implement. So this is really an opportunity for those of you who, let's say you've done a number of things within the essential practices and you feel like you're in a good place. These are other things that you can consider. So thinking about catheter harm apart from just infection. And if you advance, you can see some of the listings here. So beyond infection, we think about obstruction, unintended removal, trauma, and any time that a catheter is removed and then immediately reinserted. So this is also an opportunity to kind of bring in those multidisciplinary partners. So infection prevention, stewardship, but also thinking about our urology colleagues, thinking about how can we prevent other complications of having an indwelling catheter, like falls, for example. How can we kind of make those changes happen? So this is another consideration beyond the essential practices, so to speak. Next slide. So I mentioned this life cycle of the urinary catheter, and this is a figure that was developed initially for the compendium and then adapted for the piece that Dr. Patel and I did together. So a version of this is in the initial compendium. And as I mentioned, there's been a lot of focus, a lot of work done in the step one space on insertion of the catheter. But in this recent compendium, they really took a step back and they said, okay, what is step zero? How can we avoid using a catheter in the first place? So thinking about those appropriateness guidelines to determine that initial placement. And there's a number of work that has come out of the University of Michigan in this space. Dr. Jennifer Meddings has developed essentially appropriateness guidelines for the initial placement of a urinary catheter. So this is something that could potentially be adapted for an electronic health record where you essentially have a checklist that can be reviewed and you can see if your patient meets that checklist to have an indwelling catheter in place or if alternatives to an indwelling catheter would be more appropriate. So I think there's some really interesting work that's being done here and can potentially be kind of moved into the electronic medical record, which really helps for not just the process of quality improvement, but following implementation and really seeing those results in real time. Step one, again, insertion of the catheter, thinking about aseptic technique, precautions to minimize injury, thinking about those healthcare providers partnering for that initial insertion. Obviously, maintenance, and we think about this with a number of different healthcare associated infections. So, catheter line associated bloodstream infections comes to mind. Really thinking about the hygiene and the sterile technique. Is so important, and that is also true for CAUTI. So thinking about that closed system positioning and so forth. And then, as you can see there on the bottom, then that is a place where diagnostic stewardship can really play a role, trying to mitigate or limit the amount of urine culture ordering in that space to help kind of prevent downstream consequences. And then finally, removing the catheter and really I think what we have seen over the years is the power of nurse initiated and nurse empowered removal. So, really understanding kind of what those indications are for a catheter and when it would be appropriate for them to remove that catheter. And I think there's been a number of studies that have shown that nurse empowered removal via EHR reminders or checklists can really help kind of limit the duration of a catheter for only its necessary indication. Next slide. And you can advance. Thank you. And then, I mentioned that we've been thinking more. I mean, CAUTI is obviously the focus of a lot of what I do as an infectious disease physician, but we've also been thinking a lot more about what are some of the non-infectious complications of indwelling urinary catheters. And so this was a study that came out of the University of Michigan, and it's a really interesting study. This was a prospective cohort study of about 2,000 patients who had a newly placed indwelling catheter. And what they did was they actually called these patients at regular intervals over the first 30 days. And they called them on the phone and asked, "So, what's going on? How are you doing?" And that really was to get a sense of what are some of the complications that patients experienced with indwelling catheters at home. And as you can see, after just 30 days of an indwelling catheter, at least half, slightly more than half, reported at least one complication. And many of those complications were non infectious. So things like split stream of urine, stones, obstruction, falls, leakage, any sort of skin breakdown around the genital area. So I think really kind of highlights the other considerations to have in mind when a catheter is in place, and helps kind of troubleshoot or problem solve what might be appropriate infection prevention and just overall preventative care for an indwelling catheter, whether that's the involvement of our wound care colleagues in the setting of skin breakdown or our urology colleagues with respect to urologic issues. But a really nice kind of study to highlight that. Next slide. And that study really helped define for the compendium some of the kind of broader issues of urinary catheter harm. So, again, this figure was adapted for the article that I wrote with Dr. Patel, but the original figure is present in the compendium, and essentially looks at what are all the different potential downstream consequences of a catheter. So, thinking about those things like trauma, immobility, but also catheter associated bacteriuria, as well as CAUTI, and what can be some of the downstream effects, mostly related to inappropriate antibiotic use, the development of multi drug resistance, for example, or other complications. Next slide. I mentioned those alternatives to indwelling catheters. I know many of you are familiar with these. This is just a graphic to kind of illustrate thinking about what your hospital carries, what is to hand. So, allowing for alternatives to be considered when the urinary system needs to be managed. So, whether that's using an external catheter or a straight catheter, or even just things that are less invasive, like monitoring weight via scale, having a bedside commode to hand. So, really thinking about that step zero of the life cycle. Next slide. And so, just kind of coming home here. So, thinking about practices to avoid NCOTI prevention. So, the first being the routine collection of urine cultures. So, we know that getting a urine culture every day, for example, when you have an indwelling catheter, is hopefully no one is doing that. But, right, we know that those cultures are going to be positive. We know that the catheter system, the rates of colonization go up 3 to 7% every day that a catheter is in place. After a certain amount of time, it just hits 100%. That urine sample is going to be positive. And so, really trying to think about what are the appropriate indications for a urine culture and not collecting them as part of routine practice. Next slide. This is something that the compendium really focused on, is this idea of whether an antimicrobial or an antiseptic catheter could be helpful for prevention of infection. And, we've seen in the literature that CLABSI the antimicrobial or antiseptic catheter has been shown to be helpful for this. But for the indwelling urinary catheter, this is not the case. And just thinking about it from a scientific perspective, we know that the bladder is a dirty space. We know that there is colonization of bacteria there. And so using a catheter that is antiseptic has not been shown to be helpful. Obviously, the bloodstream is a different entity. We do not expect people to be routinely bacteremic. We expect that to be a sterile space. So there has not been evidence to suggest that these antimicrobial or antiseptic catheters are helpful. And so the compendium really recommends against that. And then, finally, this routine changing of catheters. And I will say that there's still quite a bit of debate here and not clear guidance, but this is something that the compendium suggests. So, in the case of a patient with a long-term catheter in place, and by long-term they mean greater than 7 days, that if you are collecting a specimen for urine testing, it is reasonable to consider removing and replacing that catheter for a fresh, quote unquote, fresh sample of urine. To really have a better sample in place. Again, I think, part of the issue here has been the lack of robust data in this space. We do not have a bunch of RCTs to help guide us, but we do know from the studies that are available that it is reasonable to consider this removal and replacement for collection of urine samples for catheters if that catheter has been in place for some time. Next slide. So this is an example that some may be familiar with. It's a true story. So thinking about kind of what happens in real life after these urine tests are sent. So this is an adult who is in long-term care. He loses his glasses. As you might imagine, if I would feel the same, if you lose your glasses, you just became a little bit more confused. And as part of this confusion workup, the provider ordered a UA and started him empirically on ciprofloxacin, right? And so all these little red asterisks are meant to be places where we can intervene. So ciprofloxacin is ordered. He becomes nauseated, possibly because of the ciprofloxacin. And then, as a result of being nauseated and not really taking good intake, he becomes dehydrated. In that dehydration, he is sent to the emergency room. In the emergency room, they think, well, this is probably a urinary tract infection based on this timeline. They get a urine culture. They start him on a different antibiotic, ceftriaxone. So now we've had two antibiotics. He does get better on some IV fluids, probably because he was dehydrated. But the urine culture returns with a resistant Klebsiella. And so now he is on a third antibiotic, cefepime, to cover that urine culture, and then C. difficile. So, I mean, we've probably all been on this train at some point, and I think know that this can be a really tricky path to go down, but really thinking about kind of what are those proper indications, when is it appropriate to get a urine culture, when can we kind of intervene on the initial empiric initiation of antibiotics. Next slide. So there are some great diagnostic algorithms, and the one that I am sharing with you here is freely available. This was a VA study, but it's part of a federal grant, and so it is possible to Google this and access this flashcard. So this is the Kicking CAUTI No Knee-Jerk Antibiotics campaign, and this is really to help kind of guide providers on when to obtain a urine culture. It's a handy flashcard that has a front and a back. It's based on the IDSA guidelines for asymptomatic bacteriuria and for CAUTI. So really thinking about utilizing some of these algorithms. If you're on a teaching team, for example, I know there have been times when I have kind of used this card to talk to medicine teams about, okay, walk me through your thought process for ordering a urine culture. Sort of what symptoms did this patient have that prompted you? And they might not have any of those symptoms, but the urine culture has been ordered. And it's a great learning tool to kind of talk through what those indications are. The back side of this card talks about, okay, well, if you have a urine culture and it's positive, when do you treat? When is it appropriate to treat that patient? So this is something you can access online. I think some of these tools can be really helpful for talking to providers and kind of talking about what the appropriateness of urine cultures. And that was, I think, one of the big highlights of the compendium. One of the ambitions of the compendium is that it provides you with some of these tools that can be helpful um, for preventing CAUTI. Next slide. And then I'm just going to end here with one more algorithm. This is, again, taken from the compendium. It is essentially the surveillance algorithm for CAUTI. So just walking through like how to diagnose CAUTI. And again, very similar to that initial flashcard I just showed you, thinking about how long the catheter has been in place. Is the patient symptomatic? If a urine culture is obtained, one of the things that the compendium has really highlighted is that a true adequate urine culture has less than 2 organisms. Beyond that, the concern is for contamination and without consideration for candida species, so other yeasts or molds or parasites. So those are excluded, right? We're thinking about 2 or less organisms, not yeast. And then looking at that colony forming unit. So 10 to the fifth is what the compendium recommends as kind of your benchmark for could this be a real infection in the setting of symptoms, and then treating based on your institutional guidelines. So just different ways to kind of think about teaching, think about diagnosing and appropriateness of ordering that culture in the first place. I will just end by saying that, the compendium, as I mentioned, big document, lots of things to look at, really focus on those tables. When these compendiums came out, they also came out with accompanying podcasts, which you will find on the website, the Oxford website that I linked earlier. And sometimes those podcasts can be helpful if you just kind of want a different way to absorb this information or think about some of the main takeaways. Um, and with that, I'll end. Really happy to take any questions, and thanks for the time.
Thank you for sharing with us this great information. Does anybody have questions? You can come off mute or place those in chat if you would like. I do have one question for you. In step 0, or that kind of stepping back, you had mentioned maybe using a checklist. Do you have a checklist that you recommend?
Yes, and I'm sorry I don't have this link with me, but the work of Jennifer Meddings, and I'm going to put her name in the chat. I could probably find the link, which I could send to you later. But Jennifer Meddings has done a lot of work in this space. She's out of the University of Michigan, and she has developed appropriateness guidelines for urinary catheter placement that could be adapted for an EHR, so University of Michigan.
If you
Um,
would like to share those later, I can send it out after
Absolutely.
the
Yeah,
presentation too.
absolutely.
Fantastic. Anybody else have any questions? One of the questions is, how often should we change catheters that are chronic use?
Yeah, and I think there's you'll get a varied response on this, and I don't know that the compendium has a firm recommendation. I do think that kind of standard practice is that no, essentially within 4 weeks is the recommendation, at least in discussion with my colleagues in urology, to kind of help with prevention of infection. That 4 weeks is sort of the limit. Although I have seen variation there. I've seen 4 to 6 weeks, but I think the goal is less than 4, if at all possible, before you reinsert.
We had another question that came in along the same lines, just looking for recommendations for that chronic Foley for that
Yeah,
change. And
yeah.
then also a question that says, can you talk about the difference in the Loeb's criteria in McGreer's? Is there a time to use one over the other?
Okay, great. Well, so with respect to that first question about the chronic Foley, I don't necessarily think there is in a patient who is asymptomatic who is tolerating that catheter. You definitely don't need to obtain a urine culture at that time if the patient is not symptomatic and there's not concern for that. I would think that for me, that's probably the most important thing. All of the standard kind of insertion techniques still apply in terms of hand hygiene, closed system, aseptic technique, so forth and so on. But I have seen often that at least there has been in my experience times when it's a culture is routinely obtained, and I really don't think that's necessary if the patient is asymptomatic. With respect to the second question, you're going to have to maybe clarify. I don't know that I'm maybe familiar from a layman's perspective, but lobes versus McGears. Perhaps you could come off mute.
There we go. Sorry, I couldn't
Oh yeah,
unmute. So I was
yeah.
just wondering, in long-term care especially, we see some people using McGreer's to diagnose a UTI, and some
Mhm.
people use the criteria of lobes. So I'm just curious as to, is there a best practice, when to use one over the other? Is it just a facility um, recommendation, what they decide? Do you have thoughts on that?
Yeah, no, absolutely. And I guess what I meant to say was you'll have to forgive me that I don't remember the lobes versus McGears. So can you just orient me? Is this in terms of like the diagnosis, in terms of colony forming
Yeah,
units, or yeah,
yes, it is.
yeah,
It's just like a um, criteria of when to
yep,
diagnose and actually say
yep.
you have a UTI versus not.
Yeah, and so there is a really nice table, and I was actually going to try and pull up the compendium for you here if I can find it. I had it listed. There is a nice table in the compendium that lists all of the different definitions, and the compendium itself does not provide kind of recommendations of when to use one over the other. In fact, if anything, they talk about just um, some of the benefits, but also some of the downsides of each one. And I think it just highlights how challenging it can be to sort of make these diagnoses in real time. So that I think, from let me see if I can find it for you. Just give me 1 second. Yeah, here we go. Um, okay, so can I share my screen?
You give me one moment, I can make
Sure.
you co-host and you will be able
Yeah,
to share.
great. Thank you.
It should be able to.
Great. All right, let's do this. Okay. Can you see my screen?
Yep, just came
Okay,
up.
great. So I've just pulled up one of the tables from the compendium, and really this is just to kind of provide one, like, how do we use it from a surveillance standpoint for the NHSN, right? How do we define it for the Infectious Disease Society of America, for claims based, which I'm not certain. Forgive me, I'm not certain which one Lobes falls into, but then also the revised McGreer for long-term care. So there's really kind of pluses and minuses for each, and I think they've given you kind of the strengths and limitations there. So I think a lot of it will have to be kind of a discussion with your hospital leadership about what makes the most sense in the setting that you practice, and how can it be adapted, because this is an ever-changing field, because there's a lot of ambiguity. Unlike things like CLABSI, unfortunately, CAUTI is still fairly gray. So this is, I think, helpful at least to think about some of those questions. But unfortunately, in terms of like a black and white answer, I don't have one per se. Yeah, and I will stop sharing.
Thank you for bringing that up and sharing it with
Yeah.
us. Any other questions? Oh, we have one more. It says, I am an IP in a nursing home. Most of our residents use a leg bag during the day and switch to overnight bag for bed. It becomes a dignity issue and extremely difficult to maintain a closed system. What interventions can you use?
Oh, that is an interesting question, and that certainly I think kind of speaks to some of the complexity with long-term care. You know, um, I think unfortunately my expertise probably doesn't extend to the thinking about alternatives for a closed bag system. And I think probably there's just a lot more work that needs to be done in that space. But yeah, I certainly understand why, it'd be important to sort of be able to be up and mobile and to kind of make that transition. So that's something I would have to look into. But no, I don't have any good recommendations.
Thank you. We have one more. Do you recommend replacing urinary catheter before obtaining urine specimen for testing if catheter has been in place for greater than 72 hours?
Yeah, I mean, I think we have seen kind of in the literature anything from 1 day to 14 days. I think there's a lot of variability here. I think again, it's kind of speaks to sort of the evidence that we need in this space, the work that's needed in this space. So the compendium kind of comments upon this 7-day threshold, but I think there it is reasonable to consider it even when a catheter has only been in place for a day. So I think it's sort of according to the risk of the suspicion risk and also the perspective of wanting to have that fresh sample. If it's reasonable to do so in a patient, it probably makes sense.
Just have a comment. From a guideline standpoint, we could really use a long-term care focus added to the guideline, particularly for cleaning bags between uses.
Yes, yes, absolutely. I know. And I think that's one of the issues with the compendium is its focus on acute care. It becomes hard to extrapolate it out to long-term care certainly and agree, we need a lot more work in this space.
Is there any guidance for how frequently changing IUCs is too frequent?
Not that I'm aware of, but certainly we think about all of those risks of potential trauma, right, with removal and reinsertion. So I think again, that's an area that I think is fairly gray. Um, I think when we're doing it strictly from a urine culture perspective, I think that's part of where that 7-day threshold is the desire not to have to constantly remove and reinsert with laboratory testing, but it becomes challenging, right, to weigh those risks and benefits.
All right, I'm not seeing any more questions at this point. Thank you guys. You had some great questions there.
Yeah,
Just one more comment. It's interesting that antimicrobial catheters do not help prevent CAUTI.
definitely. It is definitely interesting. And I think it makes sense logically when you kind of think about it, but in terms of the space that we're occupying, right, which is not a sterile space to begin with. Um, but it's interesting to have that data there to kind of demonstrate it. Yeah.
Absolutely. All right. I do not see any other questions or comments at this time. I want to thank you again for sharing with us today your knowledge and expertise. It really was a great topic and always a area where we're looking for more guidance and focus. Uh, let's see. I'm just making sure. They're just asking for your email. Is it okay to
Oh,
share your
sure.
VA
Yeah.
one out?
Yeah. I can put it in the chat here.
Okay, perfect. That sounds good. And I want to thank everybody for joining us today while she places that in chat. As I had mentioned before, this presentation was brought to you through a contract through the South Dakota Department of Health's HAI-AR program. Sherry Fast is now the coordinator that you can contact for that information. Oh, look at Rebecca pulled it up real quick here. Sherry's contact information is here and available for you if you would like to reach out to Sherry. Also, Rebecca and I are with the South Dakota Foundation for Medical Care and are contractors with the Department of Health for the HAI-AR contract. So we are also available to assist with any questions, resources, education that you may need. So please don't hesitate to reach out to us as well. we will go ahead and wrap up the presentation for today. Thank you guys again for joining us. And thank you, Dr. Scruggs-Witkowski, for presenting one more time.
Thanks very much.
Yep. Have a good day, everybody.
Bye-bye.